Chairperson, sirs, ladies and gentlemen, thank you very much to INASL for this opportunity. I've been given the task of speaking on transplanting patients with MASLD and HCC, prognostic markers and postoperative surveillance. Is it any different? I'd like to start with this, and I like the caption or the title of this particular article, where it said that, is it going to be the plague of the 21st century? And I think that emphasizes what's the importance of MASLD and HCC for us today. It's also said to be the malignant side of the metabolic syndrome. And if you look at the problem statement, why are we dealing here with MASLD and HCC today, or why are we giving it so much of importance? We had an SIG today morning where we discussed on this as well. It's because if you have an annual risk in HCC versus, of all the etiologies, it's somewhere between 0.5 to 5%. In MASLD cirrhosis, it's about 0.5 to 2.6%. In those series who talk about a higher incidence of HCC in patients with MASLD, it is typically those patients or that cohort which has a higher incidence of diabetes mellitus or MET ALD in them. And over the years, MASLD HCC has come to the fore as one of the major complications of MASLD. At the same time, one of the major reasons why we transplant these patients. So if you look at this data, 2010, we were speaking about 59% of patients who were already getting transplanted because they had MASLD in the US. In 2015, it was noted that there was a 9% per annum increase in the incidence of MASLD HCC who were undergoing transplant in the US. In the ELTR, and I think Dr. Russo presented this data, they found that there was a greater proportion of patients who were transplanted with MASH-associated HCC as compared to non-MASH patients. In 2019, it was quoted to be one of the fastest rising causes of HCC and the fastest growing indication for OLT. And a dynamic Markov modeling has shown that there would be a 122% predicted increase in the MASLD HCC incidence by 2030. So that's where we are as of now, and that's the reason why we need to pay attention to this. What are the issues with curative treatment in patients with MASLD HCC? They're likely to be older, and therefore they're going to have a poor performance status. Most of these patients, remember, have escaped surveillance because about 20 to 50% of these patients have developed HCC on a non-cirrhotic liver. Hence, they would present as larger tumors, they would present as an advanced stage, BCLC-C or D, and therefore a lower option for curative treatment. And I think what it highlights is our suboptimal effectiveness of HCC surveillance programs in MASLD, and I think that's a major culprit that we have to look at. I feel this is a proverb that is apt in MASLD HCC patients, and I'll talk about this and I'll come to this again, the sooner the better. This is how I'm going to divide my talk and see how we can seek optimal outcomes in these patients. Let's come to early detection. And if you want to get good results in these patients with MASLD HCC, I think early detection is the key. When we talk about surveillance, always the people who come forth say that you should survey or you should go ahead for surveillance in those patients where the risk is high and the cost-benefit ratio is good. So the annual risk of HCC, ASLD says it's 0.8%, that's when you do surveillance. Otherwise, in general, it's accepted. If you have a risk of 1.5%, you should do surveillance. What's the risk in patients with MASLD who have established cirrhosis? It's 0.7 to 2.6%. HCC in MASLD without advanced fibrosis or cirrhosis, the incidence is 0.03 per 100% years. And therefore, you would say that this is a low-risk cancer. Therefore, those people who say you should not go ahead with active surveillance is because it may not be effective in terms of a cost-to-benefit ratio if you do not have cirrhosis. But the important point is, although the HCC risk is lower in NAFLD or now MASLD patients without cirrhosis, this risk is much higher as compared to the general population. What are the recommendations for surveillance today? ASLD says surveillance only in those patients who have cirrhosis, ultrasound with or without AFP every 6 months. INASL says ultrasound every 6 months, additional individual risk assessment in F3 fibrosis. AGA says surveillance if at least 2 of the non-invasive test modalities are concordant with advanced fibrosis or cirrhosis. Each should come from one of the 3 main groups. And the latest is this German HCC S3 guideline, which says that even in patients who have MASH, not only in cirrhosis, even in patients who have MASH, you should do an ultrasound with or without an alpha-fetoprotein level. So we now have to pick up that high-risk group of patients who have advanced fibrosis and don't have cirrhosis, who should undergo surveillance. And I think these are the risk factors. If you have a type 2 DM, you have 2 or more metabolic factors, that is central obesity, hypertension, dyslipidemia, or prediabetes, and you have incidental hepatic steatosis on imaging or elevated alanine aminotransferase levels, these are those patients probably whom you should be more stringent with. When you think about surveillance or you think about doing an extended surveillance in these patients, I think you have to consider what are the risk factors for development of HCC in patients with MASLD. And these are the known risk factors: older age, male gender, presence of advanced fibrosis or cirrhosis, metabolic syndrome associated features, obesity, and more importantly, type 2 diabetes mellitus, genetic polymorphisms, especially related to PNPLA3, and current use of alcohol and tobacco. So if there is a concurrent use of alcohol and tobacco along with a MASLD in a patient who has risk factors, he is at a high risk for development of HCC. Newer kids on the block are this longitudinal change in the FIB4 index and polygenic risk scores. What in the future can be better modalities for surveillance in these patients? And I would like to point out to these 3 modalities. One, we are all aware of the GALAD score, which is a biomarker panel along with ultrasound. And you see that increase in AUC to almost about 0.98 as compared to using any of these things alone. Number 2, if you do an elastography and you find that the patient is having advanced fibrosis, that may be a reason for putting this person into a screening and surveillance program. And of course, in the future, we are looking at ctDNA and high therapeutic omics platforms to see whether we go ahead and survey these patients more. As of now, the evidence is only in hepatitis B patients and not in the MASLD patients. I think the role of abbreviated MRI is something that is there for the future. It has a better sensitivity as compared to ultrasound for early HCC detection. It's a lower cost than the full diagnostic contrast MRI, and it is as effective. And it should have a distinct advantage in those patients who have high or intermediate risk of HCC, cirrhotic patients. In patients with ultrasound visualization score C, where it is better probably to shift to AMRI in order to go ahead with screening as compared to following ultrasound. Ultrasound visualization score C is where it's very difficult in these obese patients to detect anything, leave alone an early HCC. And I'm not going to go into details of this, but this is a very nice paper published in 24, which tells you about the cost effectiveness of HCC surveillance in these patients. And Maxime Renaud and his group in France, they have talked about this fast MRI for HCC surveillance in these patients called Fast Track. Let's go to point number 2, and I want to stress that there are lesser and lesser of these patients who are somehow being referred to surgery. Given the fact that if you look at all this data and what Dr. Russo has told us, if you were to do transplant in these patients with MASLD HCC, your outcomes are as good as compared to any other patient who is undergoing transplant for MASLD, and also any other patient who is undergoing transplant for HCC, which is of any other etiology other than MASLD. Yet, we are referring lesser number of patients for transplant. And this is very clearly seen if you see that despite controlling for all this, the MASLD etiology HCCs, they have a lower chance to go to a curative treatment as compared to other patients who have HCC. Only a relatively small percent of patients are going to transplant in these patients, primarily because they are older, poor performance status, more diffuse infiltrative pattern, typically diagnosed at a more advanced stage. But it's very clear that more of these patients need to be transplanted. And this is what is the fact today, that if you were to stratify them based upon the tumor biology, you would be able to choose these patients better. And this is what has happened. If you see, the 2022 BCLC has completely changed now towards, for the first time, accepting transplant in intermediate stage HCC, considering tumor biology and downstaging in these patients. And this is the same thing that we've done in INASL. This is the PURI 3 recommendations, where again we've put in transplant in intermediate stage HCC. What's been our experience in transplanting these patients? And I think what we've done over the last few years, we started incorporating tumor biology in selecting which are the patients whom we transplant. This is our current selection criteria. It's irrespective of tumor size and number. If you don't have extrahepatic disease or major vascular invasion, we developed this competing risk regression model where we classified patients into low, moderate, and high risk. And based on this, we downstage them or go for upfront liver transplantation, depending upon which risk category they are actually falling into. These are our results for MASLD HCC. 66 pure MASLD patients. That means we have excluded MET ALD also in this particular group of patients. They were all MASLD patients. Our criteria, adult LDLTs, 66 patients. And if you see the distribution, a large proportion of them had diabetes. 25 of them had hypertension. These were the alpha-fetoprotein levels, and you'll see that only 38% of them had raised alpha-fetoprotein levels. This is something that we know now, that alpha-fetoprotein is not a very good prognostic or a screening method in these patients with NAFLD. If you see, 50% of patients were outside Milan, 37% of patients were outside UCSF criteria. Still, we were able to achieve an overall survival of 68% and a recurrence-free survival of 82% in these patients after a median follow-up of almost 5 years. Does alpha-fetoprotein stand as a good prognostic marker? You look at that AUC, it's only 0.51 for OS, it's 0.71 for RFS. And if we looked at the multivariate analysis, you will see both in overall survival and recurrence-free survival, the one that stands out is FDG18 PET avidity. So I think FDG18 PET is an excellent imaging modality in these patients, not only to find out, but also to prognosticate these patients who are going for transplantation. We presented this in ILTS in 2022 with our old data, which had 49 patients, and now we have 66 patients, and we have the same findings. Finally, post-op surveillance. Is it the same as any other patient who's undergoing transplant for MASLD HCC, or should it be different? What should you look for post-LT in these patients? I think one is to prevent the recurrence of MASH, because if MASLD comes back, if MASH comes back, you have a higher chance that he will develop HCC again. Number two is correct all the metabolic factors to make sure that you have very good diabetic control. And I don't know, the next step may be changing or modifying immunosuppression in these patients to decrease the incidence of diabetes and the recurrence of MASH in these patients. There are two things that I would like to highlight here. One is transplanting patients beyond criteria. If you were to do that, you're going to have higher HCC recurrence rates. So we have a stringent follow-up protocol in these patients, especially in those who are beyond criteria. We follow this particular protocol and we incorporate FDG18 PET if preoperatively the tumor was PET avid in these particular patients. So the goal is to pick up recurrences early. Why is it important? And we've shown this, that if you were to pick up recurrences early in these patients, and you were to use multimodality treatment to treat these patients with recurrence, you can still prolong their life for many years, even if they have HCC recurrence after transplant. Finally, I think this is something that we should not forget, and especially in this subset of MASLD patients, and that is de novo malignancy. Very less addressed issue. If you look at the causes of death beyond 1 year post-transplant, you will find that malignancy accounts for about 30% of them. And it's not only HCC, but it is de novo malignancy as well. And ILTS did a consensus conference on this, and this is the paper we published out of that ILTS SET consensus conference. We were a part of the de novo malignancy group in 2021. And you will see that in any sphere, NASH stands out. It has the highest risk of malignancy after ALD and TSC. I'm talking about de novo malignancy. And even if you have HCV and there is an overlap of NASH on that, you will find that the incidence is still higher. Finally, obesity and DM is responsible for all these malignancies. And colorectal carcinoma, again, has a very high risk in patients with MASH who undergo transplant. So to conclude, ladies and gentlemen, I think coming back to sooner the better, I think in MASLD HCC patients who are undergoing transplant, number one, early detection is important because you need to give them a curative option. The best curative option for them is surgery, and probably it's resection, and even better, I think the best is transplant. Early detection of recurrence for apt management, and I think a stringent surveillance for de novo malignancies is the take home that I would like to give you. Thank you very much for your patient listening.